Good morning. Thank you for joining us for the Ohio AAP annual meeting session on the panel of emerging science and play, hunger cues, and food allergies. I am very excited about this session because we have a variety of different specialists to speak on some different topics. So we will go ahead and get started in just a moment. Before we get started, just a few Zoom tips. Please keep your lines muted and your videos off. And you can ask any questions in the chat box, and our presenters will be checking that regularly, and there'll be some time at the end for them to also answer your questions. If you need to access anything related to the annual meeting, you can find this information on am2020.ohioaap.org, and everything that you need from MOC to CME credit is available on that website. So for our panelists, we will have Dr. Sarah Adams, who is the medical director of the Parenting at Mealtime and Playtime program with the Ohio AAP. She's a pediatrician at Akron Children's Hospital in Hudson. She is on the nominating committee and the child health pillar, and she is passionate about obesity prevention and improving mental health in children and adolescents. She will be giving an introduction of the Parenting at Mealtime and Playtime program with the Ohio AAP and some different topics in that area. We also have Kara Brogan, and she is the owner and executive director of Galvin Therapy Center. Her specialties are feeding disorders, sensory and processing disorders, and she's interested in reading, exploring the community, and walking through the neighborhood, as well as cooking. And then we also have Kristen, who's the director of operations and practicing speech language pathologist for Galvin Therapy Center too. She is a graduate of Baldwin Wallace University and Case Western Reserve University, and she has special interests in pediatric feeding, autism, and literacy. And then we also have Dr. Benjamin Prince. He is at Nationwide Children's Hospital, the director of the multidisciplinary immunolymphoproliferative clinic, and he is also assistant professor of pediatrics. He will be speaking on the food allergy component of this presentation. And we're very excited to have all of these panelists with us today, especially on a Saturday morning. So we're excited to really dive into that information. Before I pass it off to Dr. Adams, none of these speakers have any relevant financial relationships and nothing to disclose. And just a little information about our Parenting at Mealtime and Playtime program for those of you that are interested. The Parenting at Mealtime and Playtime program launched in 2014 and has impacted so many children all across Ohio, providing nutrition and activity education. PMP is transitioning away from a traditional quality improvement project to an educational-based training program, which we are really excited about the different components that this program will have. This is the first, we will have multiple trainings instead of the quality improvement project. So we will have 4 live webinars for primary care physicians and office staff to support well child visits during COVID. We've already had one of those trainings. Our next one is on December 10th on the rising importance during COVID and how important wellness is during a pandemic. We'll have 4 webinars on primary practice offices, best management, practice management, and they're listed there on the flyer as well. And then we'll have 2 webinars on best practices in the use of primary care office communication systems to track early childhood obesity and management. And then we are also very excited to be launching a PMP toolkit that will allow you to implement the Parenting at Mealtime and Playtime program into your practice with EMR tips, all kinds of PMP resources, and that will be launching in January. You can go ahead and register for that PMP toolkit using that Survey Monkey link that is listed there. It will also be sent out after this training so that you can have easy access to it. We'll also be launching a PMP journal club for MOC Part 2 credit, and you will be able to enroll in that now. So you can go ahead and sign up using that link shown there. And our resources for PMP are accessible on our website, as well as our mobile application. You can find them on the App Store and on Google Play. Some of the PMP resources that we offer are on various different topics. We have some on play, recognizing hunger and fullness cues, which we'll be talking about today, and picky eating, breastfeeding. We have so many variety of handouts. We also have age-specific handouts. We edit these handouts each year, and we are in the process of editing and getting new handouts all the time. You can check back. We're really excited to have 2 new handouts on complementary feeding, as well as playing inside during winter months in COVID. So we're very excited to launch these different handouts soon. So be on the lookout for that. And I will go ahead and pass it over to Dr. Adams to get started. Again, please ask any questions that you have in the chat box. And we are excited for this presentation. Thank you, Dr. Adams.
Hello, good morning, and thank you, Alex. So I'm really excited to be just presenting just an overview of the Parenting and Mealtime program, and I'm very excited also about our other panelists that'll be talking today. So I'm going to get started, and mine is just a brief overview, and we will go into more detail on some of the topics that I touch on today, either in our program, but also in the discussion the rest of this morning. So I'm glad that you're here. Next slide, please. So today we're gonna talk about responsive feeding and just give a little bit about hunger and fullness cues, explain breastfeeding and the well-fed infant, and also do a little introduction on donor milk, and then the importance of playtime. Next slide. Go ahead, next slide.
I'm sorry, I'm having a little bit of trouble with there we go.
Okay, so a healthy feeding relationship is so important. And in that relationship, the infant initiates and guides the feeding interaction, and the caregiver must respond early and appropriately to their hunger and fullness cues, recognizing the infant's developmental abilities and feeding skills, and then balance that with the infant's needs to help encourage that eventually self-feeding. Next slide. And the reason why this is important is that we have found out that in that first 1,000 days, so basically those 2 years, those first 2 years, very, very critical in that childhood obesity prevention. And we know that childhood obesity is on the rise. They did a study to show that 1 in 3 children that enter into preschool meet the criteria for childhood obesity. And we also know that childhood obesity and adolescent obesity brings them at risk for being obese into adulthood. And so what we want to do as caretakers is provide messages and strategies for their providers or their caregivers to improve dietary, weight, and overall health outcomes for these kids, right? So what we want to do is teach them what and how to feed infants and toddlers within the context of that growing child and be a responsive parent, right? And we've got to do it in those first 2 years, because that's when all of the brain synapses are coming together. So responsive parenting and how it relates to feeding, soothing, sleep, and physical activity, it's all interrelated. If a parent responds to those hunger and feeding cues, instead of using food as a soothing method, not only do they learn to self-regulate when they're hungry and when they're full, but we also know that they sleep better and they become more active when they're awake, and they self-regulate their own appetite. Next slide, please. So the key steps are basically really simple. The child displays a hunger signal. The caregiver interprets that signal, predicts the feeding response. The child, they feed them. The child gives a satiety signal. The caregiver stops feeding, and what do we get? We get outcomes such as healthy eating habits. The child learns, I know when I'm hungry and I know when I'm full. And it also builds stronger bonds. And guess what? Mealtime doesn't have to be a struggle. I get so many parents that, they're just like, dinner is so frustrating and it becomes a power struggle. Kids learn that mealtime can be fun. So the key principles are basically, we want to have a pleasant and warm, nurturing feeding environment. I tell parents, sit with them, sit across from them, make clear and consistent reciprocal communication and feeding expectations, offer food when they're hungry, and have predictable schedules. And make sure that it's developmentally appropriate. The beverages, healthy foods are being offered, and respond appropriately when they're hungry and also when they're full. And make sure that feeding response is emotionally supportive and, again, developmental. Next slide, please. So these are, some of the hunger cues that we see, that I'm not, you can read all of these. I don't necessarily need to go over them in detail, but the key component is that if you respond to these hunger cues, or if the parent does, then basically you're going to build a healthier relationship then in the long run. And as you can see, it's very different in regards to the different stages of development. Next slide, please. And then fullness cues. It's very important. You've got to remember to tell your families the child does not need to finish the bottle. They don't need to finish the whole jar of food or the whole thing on their plate. And a lot of times, when I'm talking to a parent and we go over their nutrition and they're very discouraged, like I make a 5-ounce bottle, but they don't quite finish it. I'll show them the growth chart and say, but look how well they're growing, how well they're gaining, and you're really doing a good job of responding to their fullness cues. And so it's so important that we tell them, and reassure them that it's not about continuing to shove that bottle in the mouth to get that last ounce in. Next slide, please. And the same with toddler fullness cues. It's you don't have to force that clean plate, because when you do, guess what? You're going to have difficulty in meal times, and we're going to learn about what to do later when that happens. You're going to have resentment and power struggles around food, and we don't want that. We want to have that, again, that responsive parenting. We want to teach them about it. I had a really funny story with an 18-month-old, and they were telling me, we're really struggling. When he's eating, we notice that he throws the food over, onto the floor. And I just happened to ask, I said, does he do that in the beginning of mealtime, or does he do it towards the end of mealtime? And they're like, well, it tends to be towards the end of mealtime. And I said, well, you know what I think? I think that's his cue to tell you, I'm done. And they laughed, and I showed him the growth curve. And I said, he's doing great. He's growing fine. That was his way of saying, I'm done. They also mentioned that the dog happens to sit, underneath his high chair. And I said, well, you might want to, that's talking about what his environment is about. I said, you might want to get the dog, not there during mealtime, because that's probably fun for him too, to feed the dog. Next slide, please. All right, I'm going to shift gears a little bit. We're going to talk about breast milk. And I think, this audience knows that breast milk is important. It's got the appropriate amount of carbohydrates, protein, fat, and it provides vitamins, minerals, digestive enzymes, and hormones that the child needs. And it contains the antibodies and lymphocytes that the mother, from the mother, that helps the baby with their immune system too. It's just gold, right? Next slide, please. And there's a marker to a well-fed baby, because I know, when I'm sure that you've heard that mom who has said to you, how do I know that they are getting enough? Because they can't measure it, and there's some anxiety around that with especially a new mom who's never breastfed before. And so remind them, these are some of the cues that you're going to see that the baby is getting enough. And so again, this slide also shows the hunger and fullness cue handout that we do have as part of our program that you can, give to the mom. We also have some great breastfeeding handouts, and we do have, as part of the program too, a wonderful breastfeeding webinar as well that I want to encourage, that, and some of these slides are taken from, that I want to encourage people to also, take advantage of. But it's really important to let them know these are some ways that you can tell that the baby has gotten enough, because as they become more and more efficient in nursing, they aren't going to nurse for 20 to 30 minutes anymore. It might just be 5 to 10 minutes and they're done. Next slide. So just talk about maybe that first week. We know that there is some weight loss in after birth, and that's normal. We want to really monitor, sometimes it can, we know that it can be up to 10, typical is about 7%, okay? So we want to tell them, like, look, this is normal. Don't immediately supplement with formula. If they are approaching that 10%, you want to assess the breastfeeding. You want to really assess how is it going. Typically after 4 days, you should start to see no more weight loss. And then at that point, 15 to 20 grams per day of weight gain after day 4. And then most babies will start to will have their birth weight gained by 14 days, some earlier, but definitely by day 14, they should regain their birth weight. There is a slower growth in breastfed infants after 3 months of age compared to those that are formula fed. And it continues after food is introduced compared to formula fed infants. I tell breastfed moms that because you might see a little bit of a change, and again, it might just be like one lower, step on the growth curve, because the growth curves are made universally. They're not necessarily just for breastfed babies, although there are some growth curves that you can get that are just specifically made for breastfed babies that do show that slower growth. And so I try to tell parents, like mothers and fathers that where the child is being breastfed, look, this is normal. This is what we expect. And so, but sometimes, you get that really chubby baby too. So it's not always the case, but it sometimes can be. Next slide, please. So mother's milk comes in around day 3 to 4. So that's why I mentioned that after day 4, you should definitely start to see, the weight loss should stop. Remember, colostrum is that first milk, and it's enough for baby for that first few days. By then, they should have no pain with the latch. The infant stays on the breast during the feeding, audible swallows, and you should start to see some transition stools by day 4. Really important to know, wet diapers can fool you. So you want to focus on the stools when you're taking a history. And infant satiety cues should be present after feeding. Next slide, please. So this is really fun. I was mentioning to my other colleagues in this presentation, I talk about poop all day, but these are the transition stools. So you can see the meconium and then all the way down into that nice, like looser yellow seedy stools. Really fun to just tell parents, day 1, 1 wet, 1 stool, etc. And it's just really easy for them to keep track of that. By day 4, you should be getting at least 4 wets, 4 stools typically. It's not gold standard, but it's just kind of an easy way to remember it. Next slide, please. And I really love this slide too. Again, I don't need to tell you guys the providers, but it's really good as a way to remind your families that, you know, the baby's stomach is very small in the beginning. And so don't be afraid to like use these common, you know, items to say, look, this is small, don't worry, to give them encouragement. Next slide, please. So 2 to 3 out of 100 can have some breast milk or milk allergies or sensitivities. And this is something that I actually see in my practice, quite honestly. What I tell families is it's most often due to cow's milk allergies. So breast milk or human milk is more heavily whey protein versus casein. Cow's milk is more casein and whey. How I remember that is I always say, breast milk is way better. So some of the symptoms are noted there, and so you can, you know, start to identify, okay, we might be getting into a milk protein insensitivity or sensitivity or allergy. Next slide, please. But go ahead, next slide. And so what you want to do is try to encourage them to continue to breastfeed through it. Ask about family history. If there is a family history of milk allergy or even other allergies, maybe start to say to them, you might want to start avoiding some of those foods, the mom avoiding those foods, even with pregnancy or during breastfeeding. But some, you know, they're still researching that as far as like how effective it can be. But we do know that breastfeeding is, especially in those first 6 months, does reduce the rates of food allergies and sensitivities. Next slide, please. Donor breast milk. This is a big buzz now. You know, this is becoming more and more popular, and donor milk, you know, is often used when mother's milk is not available. And Holder pasteurization of banked human milk is done to remove the potential harmful viral or bacterial components, but keeping the bioactive products. This is very, very important. And there's a lot of benefits of donor milk, especially we're learning in the feeding of preterm infants. And what we have found is that though some of the nutritional elements are inactivated during the pasteurization process, so they're trying really hard to keep those bioactive products, but pasteurization processing is very, very important. Okay. But some of the nutritional elements are being inactivated, but this is still greater, like it's still greater and better for the babies compared to formula. Now, for the very, very low birth weight baby or the preterm infants, the studies that they've done in NICUs that shows that it's still, you know, it's better for those babies, and that's why they'll add the fortifiers, and this is showing some amazing benefits. Now, what's super cool about this too, and I have included at the end of this presentation the resources regarding this, all the information on this slide, is that it increases the rate. They found with these very low birth weight babies that it increases the rates of breastfeeding, which is awesome. So it's very, very important that you remind the families they need to consult their provider, because safety, the source of where they're getting the donor milk, the screening, you know, making sure that there is a pasteurization process, and how this donor milk has been stored is very, very important. The FDA is advising against acquiring it from just an individual or some random internet. And so, you know, and I've included the resource regarding where the FDA recommends obtaining this donor milk. And again, the information is at the end of the presentation. It's just very, very important if you're going to guide your families about donor milk, where to get it, and more information about it, because again, it can be if it doesn't go through the pasteurization process, there are potential harmful viral or bacterial components that can be very, very risky for the infant. Next slide, please. So in the last few minutes of what I want to talk about, I just want to say complementary foods, again, very important to encourage them to start with iron and zinc, promote vitamin C to promote iron absorption. And next slide, please. And, you know, we remember that all of the complementary foods are to promote energy. I'm going to kind of fly through this just as a matter of time, but you know, I think you guys already know a lot about this already. Next slide, please. And the important thing, there's a lot of information on this slide, but what I want to mention is this, that it's very, very important. Children can learn to accept bitter flavors, which is characterized by most vegetables, right? They can learn to do this. They can learn to accept and like healthy foods with bitter and sour taste, repeated exposure. So offering infants a variety of vegetables compared to offering them the same vegetable repeatedly has been shown to increase acceptance and lead to greater amounts of each of the non-vegetables consumed. So different foods, different textures, over and over and over, 6 to 35 exposures. Just keep telling them, keep trying. And the good news is breastfeeding can facilitate the acceptance of these solid foods because of the result of the variety of a diet that a mom already has. Remember, this is their window of opportunity. This is our opportunity to teach kids to eat healthy, nutritious diets. Next slide. So, next slide, please. You know, we know that toddlers, you know, they start to get picky, right? And we're going to hear more about this. And we also know that the school age kids, man, they're snackers, right? Toddlers, school age, they like snacks. They just are getting inadequate amounts of fruits and vegetables. So this is why it's important. You know, we want to tell them no sugar or no sugar sweetened foods and beverages. It's just so important that we teach them young so that they can learn and develop those skills by the time they become school age kids, because they also start to develop that we want to develop that healthy body image too. Next slide. So play is serious business. So here's the deal. Why is it serious? Because we know that it optimizes physical development and it manages toxic stress. Research has shown that play is the single most opportunity to build social, emotional, cognitive, language, and self-regulating skills, right? We want them to build a safe, stable, and nurturing relationship too with their families. And play does this. You know I get super excited about this. And there is a wonderful webinar that's goes into a lot more detail about this that Dr. Murray does, and we're really thankful for him. We know it enhances brain structure and function and promotes executive functioning. Next slide, please. So playtime and physical activity, it is based on developmental stage. You know, each developmental stage offers them the opportunity to build motion, agility, coordination, balance, flexibility. Family schedules, we know they're so busy, you know, but that's okay. Build it in. Make a preference for activity. It doesn't have to be anything big. It can just be small. It can be structured. It can be less structured. And we have an amazing handout on play that you can give parents. We have a new webinar coming next year in February about play indoors, because we know that the weather's going to get bad and we're going to have a new handout about that time. But playtime with purpose is so important. And we can teach our families from tummy time all the way up to that 60 minutes or more of physical activity. And I tell parents, 60 minutes sounds like a lot, but break it down, especially now that kids are doing virtual learning. I tell them, take some breaks and just stand up, stretch, do yoga. It doesn't have to be big. And I tell them they don't have to be in a physical sport. And we know they're not, some of them aren't even able to do their sports. So do something together. Next slide, please. Use the 5 senses, use toys that have texture, size, shape, light, sounds, right? Talk and sing. Belly time with toys out of reach and to the side. Play games, run, climb, kick, all those things, And then as they grow and develop, printing, drawing, games, puzzles, like you can see all of these things have something to do with their developmental stage. And we know that play and stress are linked. We know that more play decreases cortisol. We know that play increases their chance of a decreasing, having a healthy weight and endocrine and a cardiovascular system. But we also know that play increases our immune system. Wow, what a way to prevent flu. What a way to prevent COVID. Next slide, please. So how can adults help? Well, talk face-to-face, sit, touch, smile. The other thing I want to mention is, and I know she's telling me my time is up, but I'm almost done, I promise. It's that interactive, serve and return. Serve and return, easy to tell your parents. Serve and return is so important for that emotional connection as well. So basically what that does is you talk to the child and they come back to you. So these are some ideas with babies. And next slide, please. And again, this also shows the different, again, at 1, at 2, and at 3, what the different things that adults can help children do. And next slide, please. And we know that play is good for all of us. It builds strength, muscle, and coordination. It burns calories. In this day and age right now, where there is so much anxiety and stress, not just obviously with the older children, but with our younger children too, play is so good for us. And we also know that play is good for the caretaker as well. Their studies have shown that it reduces stress in the caregiver as well. It raises self-esteem. It gives the kids the social skills and that executive functioning, and it improves attention and behavior. And I just can't say enough about how important it is. And I know that our practices are so busy. And I know yesterday it said that, the average time that a primary care provider has with patients is like 13.5 minutes. And we have so much to cover. But if you can just encourage our families not to forget about play. And I really encourage you in February to sign up for the webinar on playing indoors so that we can encourage our families, especially during this winter time, to get ideas on how to play inside as well. So thank you so much for joining me today. And please, I hope you'll take advantage of our PMP that's not QI, it's now educational. You don't have to do any data or charts. I really hope you'll take advantage of this. So thank you again.
Great, thank you, Dr. Adams. And I apologize for some of the slide delay. For some reason, my computer is sticking. But thank you, everyone. That is our first portion, and resources are here. These resources will be available on the annual meeting website. And if you have any questions, I am the program manager for Parenting at Mealtime and Playtime, and my email address is listed there. Now I will stop talking so that Kristen and Kara can share their screen.
All right, thank you. So we're going to talk about guiding parents through feeding development. And I am Kristen Skibo. I'm a speech pathologist, and my colleague Kara Brogan, who's an occupational therapist, will be joining us in a little bit. We're both from the Galvin Therapy Center, and we're a private pediatric practice up in Cleveland. We have 2 locations, and we found that feeding really has turned out to be a large part of our population. There's really a big need for feeding therapy that is outside of a hospital system, and so here we are. Our goal for today is to identify strategies and resources to support parents through the development of feeding skills, whether this be typical or atypical development. And so our goal is really to create a toolkit for you all to share with your patients so that you can help them with any small feeding challenges in the hopes of preventing larger feeding problems. And then of course, also to be able to support them when there really is a problem that would warrant intervention. So we've attached a handout of feeding developmental milestones that is, it should be within the conference presentation website. We have a bunch of handouts for you to share with your families and patients, and we hope that these are helpful for you. We'll highlight some of them within here, but I believe there are 10 different handouts that you can access later. So in this newborn to 4-month-old stage, eating is very reflexive. There are 4 different reflexes that are important for eating: the rooting reflex, the suck and swallow reflex, the tongue thrust reflex, and then of course your gag reflex, which is much stronger and not as far back as it is in adults. So this is of course for protection of the airway. So eating should be really comfortable and enjoyable for babies. And if they're not enjoying it, if they're not comfortable, if they're showing signs of pain, then that might be indicative of a bigger problem. So here are some solutions of things that you might be able to advise parents that would help with some of those feeding problems at this stage in the game. Of course, vomiting and arching could be indicative of reflux or colic or allergies. Poor weight gain might mean that mom isn't producing enough milk to sustain them, and then we might need to consider other formulas for supplementation. At any age, regardless of where they are, we don't want to hear a gurgly, wet vocal quality after eating. We don't want repeated episodes of choking. We don't want frequent respiratory illnesses. Of course, those might be signs of aspiration. So that would be dangerous and something that would indicate that we need to look a little bit further. For 6-month-olds, now your feeding reflexes have been integrated. So eating is a learned behavior. Caregivers' praise and attention will reinforce the behavior of eating, but on the flip side of that, any pain or discomfort will reinforce not eating. So at any stage, again, motor skills have to be progressing to support the continued feeding development. At this age, we want our kiddos to have good head control and be able to sit with support. The body prioritizes breath and postural stability before eating. So it's really important that we're selecting high chairs that are adjustable and that provide good support. And we'll show you some examples of things that we use in our clinic in just a minute. Another thing that I wanted to say at this stage is that we know that baby-led weaning is a really hot topic, essentially skipping over those spoon-fed purees in favor of table foods that babies can grasp, but we don't want babies to skip over purees. This is how they learn how to control their lips as they clear the puree from the spoon or their fingers. And of course, it also gives parents a chance to expose them to lots of different flavors and textures and do so safely. So that's an important step. So I want to show you real quick. Let me see if I can get out of this. A couple of handouts. So these are our product recommendations for seating during meal times. These are things that we use in our clinic. What we're looking for in a high chair is support, of course, as the primary, safety. Anything that's adjustable, you want the height to match the table that the child is eating at. And so these are some of our favorite products here. The Graco Duo Diner, the Kikaroo, and the Trip Trap chair, which have lots of different accessories that you can do attach to build support. Booster seats, we're looking for the same criteria as the high chairs. You likely won't need these if you purchase one of these adjustable high chairs above. And the thing that we want to avoid are those bumbo seats and other seats on the floor. They put the baby's hips in a really unnatural position, and that doesn't help them strengthen the core muscles they need for postural stability. The other thing I wanted to show you are some of the products that we use in therapy for oral motor and feeding development. And again, we have no association with any of these products. We're just sharing some of the things that work well for us in our clinic. We're always looking for products that are going to support oral motor development and not hinder it. So as far as pacifiers go, we don't want babies to get stuck in a suckling pattern or to develop an open mouth posture from frequent pacifier use. We want them to move on to that sucking. And these are other tools that allow for more sensory exploration and other motions like chewing for soothing. Cups. We do not prefer sippy cups. They're really more designed for preventing spills than they are for oral motor development. They can impact kids' dentition and prevent development of a mature swallow pattern. So we like to teach straw drinking early on, and we have some handouts of how to do that and how to help parents do that. Again, you'll find those in the conference website. We like those straw cups. We like the open cups for purposes of drinking. As far as utensils go, we want to choose spoons, of course, that babies can fit inside their mouths, that they can clear food off of, and that give them a manageable sized bite or a manageable sized portion. These tasting spoons are really great for introducing new foods. They're not so intimidating, and babies can practice holding them to feed themselves. The mesh feeders are really great for introducing new tastes and practicing chewing and biting safely without the risk of choking. And then our kids love these little kid-safe knives that they cannot injure themselves on. The knives are very safe for them to use. And so they love to be able to practice chopping and cutting and feel like they're part of preparing the meals. And then we have some fun plates and mats too. The things that we want to avoid, I already mentioned the sippy cups, but also those food pouches, the vegetables or fruits that are in the little suckable pouches. They really don't allow for kids to practice chewing foods in their whole form or practice with utensil use. So there's no variation in texture. They're usually smooth purees. So we really, advise to use those sparingly. All right, let me get back here. All right, so for our 9-month-olds, similar ideas apply here as for all the rest of the stages. We want to see continued gross motor development and oral motor skill development. These kiddos are independent sitters. They should have better head control at this point. We're activating their lips and tongue with different flavors and textures via spoon feedings and via cup. This is a really important feeding stage because now the babies can separate their tongues from their jaws and the tongue movements differentiate. So this allows them to start moving pieces of food laterally for future chewing. For our 12-month-olds, now they have that pincer grasp mastered and they really want to start feeding themselves. So from an oral motor standpoint, they can chew softer meats and most table foods now. So the focus of this stage is more on food exploration. So we want to see a variety of flavors, textures, and of course, nutritional food groups represented in their diet. So just as Dr. Adams was telling us, we want to expose them to lots and lots of tastes and textures. For our 15-month-olds, now we're starting to see the finessing of all the eating skills. So improving the timing and coordination of biting, chewing, and swallowing, also better jaw stabilization and control of the tongue and lips for drinking. Kids at this age are also, of course, becoming more vocal about what they like and don't like. So you might start to see some behaviors around mealtime. It's important for parents to present the foods to them multiple times. Feeding research says, at least 10 trials of foods to decide if you like it. So to keep trying different textures, flavors, and different foods. By age 2, they should have all the oral motor skills that they need for the rest of their lives. So the oral motor movements are much more precise and coordinated. They have a mature rotary chewing pattern. They can grade their biting and chewing. They can transfer food with the tongue. They can coordinate their lips with their jaw in order to drink. And they're not as messy because they have a little bit more control. So at this point, they can technically handle any food or liquid. And we just need to focus on continued exposure to a variety of different foods, as well as continued structure, and positive language around meal times so that children establish healthy relationships with eating. I wanted to show you another one of our handouts here that we've developed that includes a nice little summary of what kids should be eating at different ages. So it kind of goes through the different food groups as well as the different serving sizes. So you guys will have access to this. And also some general tips and tricks and language that is helpful to use and language that you might want to avoid. So this is a nice summary of red flags for feeding disorders. So any of these things at any stage of development can be indicative of a deeper feeding problem. And this was developed, I want to make sure that I give credit where credit is due, by Dr. Kay Toomey, who is out of the Star Center for Sensory Processing Disorders in Denver, Colorado. And I'm not going to read through these all right here, but again, these are cues that something deeper is going on from a structural, medical, or skill building standpoint. So when parents are repeatedly reporting challenges getting the child fed, that's usually a great indicator that there's something underlying that we need to figure out. Education and prevention, we've reviewed some of these handouts already real quick, but here is the whole list. And again, those will be accessible to you to share with your clients and families, and we really hope that these are helpful for you. So again, from Dr. Toomey, this slide here is about picky eaters versus problem feeders. So this gives a bit of information on when the feeding issues start to become clinical. The picky eater side are the kiddos who will respond to some of those preventative tips and strategies that we've discussed on our previous slides, while the problem feeder side encompasses those kids who we are going to want to see in feeding therapy. So at this point, I'm going to turn it over to my colleague, Kara, who will talk a little bit more about our process of evaluating and treating children with feeding disorders.
Okay, so the children who are referred to us for feeding evaluations often already have had a medical intervention prior to their first visit with us. We often see pediatricians who are sending us their patients after a GI workup, swallow studies that they've already checked for tethered oral tissues, allergy testing, if there are any signs or symptoms present, and if there are any concerns with growth, either too much weight gain or not enough. One thing that we do recommend is that rather than waiting and seeing, is referring on for a feeding evaluation so that we can support the child and the family at the earliest stage possible. We have much better outcome the earlier we intervene. And most of our referrals present with parental stress and significant challenges at mealtime. We hear that from parents over and over again. Our evaluations always start with a thorough review of the medical history, and if they've already had therapy, what they've done, what worked, what didn't work. We interview the parents or caregivers thoroughly so that we get a really good sense of how feeding looks like for the child, how a mealtime looks like in the family and at the house, and if there's any other feeders in the caregiving realm at daycare or school or something like that. This really helps us get a good picture of where the child is struggling and how to support the parents. Diving in a little deeper, we go into what they're eating. We obtain all the information on their routines with eating, how often they eat. So we look at all of these types of details to, again, help build a further picture of what the child is struggling with or what they're having success with. At this point in our evals, we are able to use direct observation with any of their physical abilities and skill development. We essentially set the stage for a mealtime in our clinic. We have the parents bring foods that the child loves, that the child hates, that they're typically exposed to in their home environment. And we're able to assess their abilities with biting, chewing, swallowing, along with their sensory abilities, breath control, and postural stability. Sensory processing related to food is another component that we address in our evaluation. We do this both through observation and also through questionnaires for the parent, and if age appropriate, through with the child as well. We do see teenagers or older children, older school age children who have feeding disorders, and they have distinct opinions and a voice to share. So it's very important that we bring the child in to the evaluation with the Q&A portion as well. You can see the list of people who we have typically in a feeding evaluation as far as team members. At our clinic, we have OT, PT, speech, and everybody else we conference call or we communicate with, especially our dietitians. This seems to be one that we get referrals from often, and also we rely on them quite frequently for any recommendations. We have we have many goals on our treatment plans, but two very important goals for any of our children with feeding challenges. One, our main goal is to create a positive mealtime experience for the child and the family. We really want to take away the stress and the pressure of eating. So that's important. The other one is we have a standard goal for the child with the foods they eat, and they have to have 10 foods in each of the three main categories of 10 starches, 10 proteins, 10 fruits and vegetables. And the reason for this is so that there's enough variety that we can diversify their diet day to day so that we don't have as many issues with food jags. And it's really helpful that way. So we obviously drill down into some of the components that need to happen before we hit the stage of the 10 foods and a pleasant mealtime experience. So we can address any of the oral motor skills that are missing, any of the anxiety that we're seeing. And we also definitively include parent education. It's a huge component. In order for us to have good carryover in the home environment, we have to make sure that our parents not only are aware of, but are educated enough to follow through with our recommendations. When we are developing the feeding plan, the treatment plan, we don't look at this as a one-size-fits-all model. We've had training in multiple different methods and strategies, and so we use that as our background knowledge when we're looking at the parents' culture and beliefs around feeding, but also parenting. We look at the child's development and their cognitive skills, and what has been used successfully in the past or unsuccessfully to determine the best approach. Okay, so here we have some examples of our feeding sessions, just to give you a glimpse into the world of feeding therapy. In this first video, you'll see that our feeding sessions start with sensory preparation. The purpose here is to engage the child, build a bit of joy into the session to reduce any of the anxieties that might be present, but also to give the body input necessary so that they can sit and focus for the eating session. We then transition from the sensory prep time to hand washing. We really emphasize vocalizing and having a routine for the transitions, and that the transition from sensory prep is to hand washing so that they don't automatically go into a state of distress and worry. We use hand washing also to have a time for blowing bubbles and doing some breath work so that their postural support and their breath control are also set. It's stuck. Yeah. In the next couple of videos, you're going to see how we're moving into our session. We start with oral motor skill building when it's necessary. This can be used with oral motor tools, but also with food to build oral motor skills. The idea is to get as many repetitions to build that motor plan with whatever skill that we're addressing for that session or for that child. So in the next videos, you'll see we have our little girl who's 4. She is typically developing. She does have tethered oral tissues that have not been modified, and she has no additional medical issues. She's going to be working on some biting and chewing skills with tools and tongue and lip use with some food. We make sure that we use tactile, visual, and verbal cues to support skill development.
This is all crumbly. Crumbly. Oh, let your lips. Oh, over your lips. You lick down on the outside. Oh, let your tongue on the outside. So far, you can always have your water to help it go down. That's pretty dry.
Okay, in this next video, you'll see our 5-year-old who is on the autism spectrum disorder. He has extreme picky eating. We focus on independent feeding of his preferred foods while building tolerance for novel foods. We work on a hierarchy of tolerance. So sometimes it's simply being able to sit at a table with food, even 12 inches away, moving up into being able to touch, taste, smell, and exploring the food through the different sensory systems.
Everybody gets the orange.
Okay, in this next video, we're pairing familiar foods together using a behavioral method. So this behavioral reinforcement is used to increase the trials and build tolerance for new foods together, bite size, and repeated bites. You'll see ignoring of the comments from the little one of this is yucky, and we just keep moving forward, giving alternative choices if the bite seems too big or too much for her, and a preferred reinforcer given after each bite. So she's really into stickers and likes to collect them all over her shirt or a piece of paper. So that's what we use for this session to reinforce the good work and the hard work that she's doing. She also has been taught to use a water as a quick liquid wash to help any food go down that she feels is too big or too sticky, or that she can't use her tongue to clear from her teeth or her cheeks. The additional piece of using the water is to help a food that she doesn't love go down. So it's not about skill ability with that, it's more about she doesn't like the taste of it. So we often teach our children that you don't have to love every food to eat it. It doesn't have to be your most favorite. It's not your top 5, but you can still have some strategies to help you get the food down.
It's called banana yogurt with granola. Just do your quick taste first. Yeah, there's a tiny taste. It's banana. You like banana and you like yogurt. Those are 2 things you like together. Right? Yes, you do. And you read those stickers. Are we going to put them on your hands and arms like last time? We don't have to put them. You want them on your shirt? Okay. Yeah, that's all right. It's just fun. The process. So you can take a bite, and then if you need water, you can have your simple water. Let's do 5 bites of yogurt, and then we'll move on to tasting. That was fun. It's 4. You got this. Yep. You have 4 apples and a rainbow. Oh, you want 3 apples and 2 rainbows? Okay, deal. 2 rainbows.
Okay, in this last treatment video, we're working on mixed textures, varying spoons and bite sizes. This little girl has a great vocabulary and innate curiosity, so we really use that in our treatment sessions to boost feeding. We pull in her cognitive skills to help alleviate her worries around eating, but you also see she can quickly use it as a distraction. We do have a cleanup routine at the end of our sessions. So we have the children blow food into a garbage bowl or spit it out like a rocket. We make cleanup fun. However, we have an ulterior motive that it also gets a chance for that child to have more experiences with the food. Sometimes for some of our children, we have more interaction with the food at the end when we're cleaning up than we do throughout the whole sessions. Also, if what Dr. Adams was talking about earlier, when kids throw the food, we ignore it until the very end, and then they are in charge of cleaning it up.
Sometimes there's chunks of this, and sometimes it's smooth. It can be smooth and chunky at the same time. Okay, this way. Yeah, let's see. You tell me if it's smooth or chunky. It is smooth. Okay. Should I see if it's chunky? I don't know if it's chunky or not. You have to tell me. Smooth or chunky? It is even more yellow. Good. It's good fit time.
Okay, sorry about that little glitch. So we have a couple more videos I'm going to run through really quickly that we have for specific cup drinking, spoon use, and things like that. So first we have cup drinking. We're using a hand over hand method because this is a new skill, and it's a paired reinforcer. Again, using an ABA or a behavioral method to help get more frequency of trials so that this is an enjoyable and easier task.
You ready for some water? Water, please. Take your drink. Let's go around and round and round all through the town.
Our next video is for spoon feeding. Here we reinforce the angle of the spoon to go below the bowl of the spoon. This, and placing it a few inches away from the mouth. So this helps the child initiate the taste by going forward and encourages the use of the lips to pull the food from the bowl of the spoon.
There's a new taste. It's called banana yogurt with granola. Just do your quick taste first. Yeah, there's a tiny taste.
In this next video, this is creating tolerance for spoon Feeding, we are using a dry spoon technique, giving him lots of opportunities to have the spoon in the mouth and how it feels, and variety of spoons so that he doesn't get stuck on one type of spoon. So we're creating generalization here.
Open wide. 1, 2, 3. Open wide. 2. Open wide. 3.
Next, we have our little one using the fresh food feeder. So she is very hesitant to put whole foods in her mouth. This allows her to put the whole food in her mouth, this being an apple, and get the experience of chewing, but also managing the juices and the tiny bits that fall through the mesh bag.
Mesh bag. Yeah, gotcha. That's the best biting down. That was really nice. It is an apple. It is an apple. Now do the side teeth.
In this next video, we're using hard meltables. These are foods that start off as firm, but within just a few seconds will melt to mush in their mouth. So it's a nice, safe food to use when they're learning to chew.
Okay, which side do you want? Right side or left side? Okay, open wide. Really wide, like wider. Yeah, wider. Hey, that's my finger. Yeah. Try again. Really wide, wider. Crush it. Get it in there. Crush it. Open. Close. Open. Close. Open. Close. Smush.
Okay, and the last one, we also use harder foods, crunchy foods for biting and chewing practice. We are teaching her to spit so that she feels safe if the food is too overwhelming for her. And also, again, the water wash.
Oh. Hold it and you do the chewing. On those backwards. Oh, you did it. You crunched it. See? It fell out. You crunched it in half. Do it again. Yeah, up and down, open up and down. Use your tongue. Use your tongue to move it. Okay. You can swallow it now. It's tiny. If it's too dangerous for you, then spit it out.
And there we are. That is essentially what a little clips of a session would look like for us and all the variety of skills that we would teach.
Great. Thank you, Kristen and Kara, for presenting on those really important topics. You both have a lot of questions in the chat box. So if you want to go through and look at those and answer some of them in the chat box, and then at the end, we should have a few minutes for you to talk in person as well.
Great, thank you.
Thank you. And then Dr. Prince, if you could stop sharing your screen, and Dr. Prince will share his. Kristen, are you able to stop sharing your screen? Perfect, thank you.
There we go. Okay. Well, this has been a really fantastic session so far. I mean, I've actually honestly learned a lot, and I'm glad I have the privilege of also talking to you guys today. I'm going to speak really on aspects of food allergy, and my goal is to give you guys some really practical tips that you can apply directly to your practice, and we'll try to make this as interactive as possible and maybe have some fun at the same time. So first, I have no relevant disclosures for today's talk, and these are my objectives. So just to start off, let me minimize minimize this real quick. So this is sort of the broad sort of God's eye view of kind of how I think about adverse reactions to foods. And I use this sort of perspective when I'm speaking to residents and fellows, as well as parents and patients. And so a lot of times people will use the term food allergy to really indicate any adverse reaction that could be occurring because of a food. But I tend to use the term food allergy when really your immune system is involved. And so I think that this is a very nice, easy differentiation to sort of start to think about various adverse reactions to foods. So is your immune system involved, or is your immune system not involved? And there are a lot of different various types of both immune-mediated adverse reactions to foods as well as non-immune-mediated reactions to foods. So first, in the non-immune-mediated reactions to foods, you could have toxic and pharmacologic adverse reactions to foods, such as bacterial food poisoning, or drinking a lot of caffeine and making you feel jittery or tachycardic. You can also have non-toxic, non-immune-mediated adverse reactions to foods, such as intolerances, galactosemia, or just various idiosyncratic reactions to foods that don't really have a very clear etiology or pathophysiology behind it. Unfortunately, these kinds of reactions, there's not a lot of testing. There is some testing for some of these mechanisms and some of these processes, but a lot of them are really made by history and sort of it's a clinical diagnosis. On the left are various types of immune-mediated reactions to foods, or as I would say, food allergies. And you can divide these up in many different ways. For the purposes of this slide, I've sort of separated things out based on whether or not IgE, so your allergic antibody, is implicated or involved in the reaction. And so on the left, you have your very strict IgE-mediated reactions to foods, such as anaphylaxis or contact urticaria. On the right, you can have non-IgE mediated reactions to foods where there's clearly no implication or involvement of IgE, such as in celiac disease or allergic contact dermatitis. And then there are some diseases sort of in the middle ground where IgE may be involved, but it's not the whole picture. There are other aspects that lead to the presentation of that manifestation of food allergy. And for the purpose of this talk, I'm going to really focus on these various immune-mediated reactions to foods. So even though we're virtual, I like to include cases because I think that it's a really nice way to sort of apply things clinically and maybe remember things a little bit better as you're seeing patients in your setting. So for our first case, you are seeing a 6-month-old healthy male with a parental history of food allergy who's presenting with a history of isolated hives at their face and neck associated with ingestion of strawberries and tomatoes. The parents are concerned about a food allergy, particularly given their history. And so the question is, what are the next best steps in management? So do you want to send a specific IgE test for a red dye? Do you want to send an IgE food allergy panel? Would you like to refer to allergy immunology, or offer reassurance and recommend reintroduction? And so we're going to do a quick poll. So if you guys want to go ahead and select what you think is the best management or the best next step in management, we'll give you a couple seconds here. All right. So it looks like 59% would like to offer reassurance and recommending reintroduction. And I would actually agree with you guys. So if we can, there we go. So that was actually the answer I was looking for. And really what's going on in this case is really food-associated acute urticaria and or just contact rashes secondary to the foods. This is much more common in children, and for various reasons. So one is children tend to have more sensitive skin. They also tend to have a lot more contact in the process of consuming their food, as we've heard a lot already about. And so as people use more utensils and provide less contact with the skin, these kind of reactions become less of an issue. But why it's important to get a good history is because it can actually represent an IgE-mediated reaction to a food. Now, more commonly, you're going to probably see this more than an IgE-mediated reaction to food, and some tips that you can think of. So usually these kinds of reactions, if it's happening to foods that are not common causes of food allergy. So in this case, it was strawberry and tomato. These are not common causes of IgE-mediated food allergy. If you have patients that have more sensitive skin, if they're reacting or having reactions to multiple different foods, this can kind of be a hint or maybe a pointer that this is what's going on. And a clinical pearl that I'll leave you with is that if you are seeing this sort of isolated intermittent contact, either hives or just sort of rashes, usually on the face or the neck area with multiple different foods, but otherwise tolerance is good. There's no other reactions that you're seeing. And another kind of point that I usually look for is if the child's enjoying the food, they're having fun with it, it's probably unlikely to be an actual food allergy. Now, when we talk about actual IgE-mediated food allergy, the most common foods that are implicated in IgE-mediated food allergy are going to be milk, egg, peanut, tree nuts, soy, wheat, fish, and shellfish. And sesame is sort of going to round out the top 9. I have milk, egg, and peanut highlighted because those are going to be the most common foods that you're going to see in sort of infants and young children. And some of the other ones you might see more, as the child gets older and starts eating various different kinds of foods. So what you tend to see in these kinds of reactions are you're going to see typical IgE-mediated symptoms. So you can see those cutaneous reactions, hives, flushing, swelling, but usually you're also going to see other things like respiratory symptoms of rhinitis, coughing or wheezing, GI symptoms such as vomiting or abdominal pain, cardiovascular symptoms like hypotension, and some of those older kids that can be more verbal and explain to you what they're feeling, they'll sometimes have more CNS-like symptoms of feeling lightheaded or even kind of explaining or describing this feeling of impending doom. Now, the types of symptoms that you should see are there, and really the other big important piece of making the diagnosis is that those symptoms usually happen pretty immediately after eating the food. And so when you're getting a history on, when you're concerned about potentially an IgE-mediated food allergy reaction, you're getting that history, you don't need to go back and get a history of what they ate, 4 and 5 hours before. You're really only asking about those foods that they ate, 1 to 2 hours before this potential reaction occurred, because that's really the timing that you're going to see. Furthermore, these reactions should be reproducible, and they should react to every different kind of food in that food group. So if you're allergic to dairy, you're not just going to react to milk, but you're also going to react to cheeses or yogurts and ice creams. And so those are some important questions to ask that can help weed out maybe an IgE-mediated food allergy, or maybe make it more likely as well. And then finally, as you can imagine, some of these symptoms like coughing or vomiting, along with hives, can also be seen in viral illnesses, viral gastroenteritis, or like a viral URI. And so one helpful kind of point to differentiate these kinds of reactions from those infectious kind of associated symptoms would be that usually an IgE-mediated food allergy isn't going to be ongoing for more than 24 hours. So if you have a rash or hives or coughing or vomiting that's going on for more than 24 hours, it's less likely to be an IgE-mediated food allergy. Now, I oftentimes get asked questions about, well, what are some risks for developing an IgE-mediated food allergy? And so really the 2 biggest risks that you're going to see are either having a personal history of eczema or having a personal history of another food allergy. And really the reason behind the first one is that this is often thought to be the start of the atopic march. So when you have a broken or a less intact skin barrier and you're experiencing proteins that from either food proteins or other proteins through a porous skin barrier, you're more likely to initiate an inflammatory response, develop sensitization, and things of that nature. And a lot of studies on both of these are in the Australian data. There are several studies within sort of the health nuts cohort of patients, very aptly named. But what they have shown is that in these Australian infants, 50% of these infants who have early onset eczema, defined by really requiring a prescription topical steroid and starting within the first 3 or 4 months of life, end up having a food allergy to either peanut, egg, or sesame by 1 year of age. Pretty significant. In the same cohort, they show that if you have a history of egg allergy, 11% of those patients will end up having a peanut allergy by the year of 1. And so there are other risk factors like asthma and other atopic diseases, as well as having a sibling history, but I would argue that these are much less significant. And in fact, like for example, in the sibling history piece, a lot of that data comes from retrospective studies and or surveys. And so what you'll see are parents, with an older child that has a food allergy being nervous to feed the younger children. And so because of that, there's delayed introduction. And we're going to talk about how that can also play a role in the development of food allergy in a little bit. So when you are seeing history or symptoms that are consistent with an IgE-mediated food allergy, what are some important questions to ask? So first off, you want to ask about the kinds of foods that they were eating, in that 1 to 2 hours prior to them developing symptoms. I always ask about those top 8 highly allergenic foods because it's more likely that those are going to be a trigger than something that's more obscure. So can you find somebody that actually reacts to red dye? Absolutely, it's a real thing, but much less common than having a reaction to milk, egg, peanut, and some of those other foods. I ask about also how the food was prepared. So certain foods, such as milk and egg, you can be allergic to the lightly cooked or frank version of that food. So when I say lightly cooked, I mean like for eggs, scrambled eggs, or an omelet. For milk, I mean yogurt, I mean cheese. But you can be allergic to those, but still tolerate that ingredient in a baked form. And so we don't typically, if the child is tolerating it in the baked form for milk and egg, we don't remove that food from the diet because that can actually help them ultimately outgrow their milk or egg allergy. So I definitely ask about food preparation. I ask about exposure. So I know that if you're thinking sort of academically speaking, you might be thinking, well, they need to be exposed at least one time first before they develop a reaction. Well, while that's true, you have to become sensitized first. You're not born with a food allergy. Oftentimes, as I mentioned, these kids are being sensitized through their skin. And so you might actually have a patient that reacts upon their first ingestion. And what happened is they became exposed and sensitized through their uncontrolled eczema, for example. I also ask about, when the last time they tolerated the food. So, if they have had it before, when's the last time that happened? If they just tolerated the day before and they ate a decent amount of it, it's less likely that maybe that food was implicated in causing the reaction. And I mentioned the piece about asking about how much they ate because I have definitely had parents come in and say, oh, they've been eating peanut for 3 months, peanut butter. And I'll say, well, how much are you giving them? And they'll tell me, oh, just a little smear on a cracker because they're nervous to give more. And when they finally ate a larger amount, they actually had a reaction. So don't be fooled. Make sure you ask about exactly how much and what they were eating. And then if it's not clear on initial history, which I will tell you for IgE-mediated food allergy, it usually is pretty clear because of the the very short duration of symptoms and then short onset after eating the food. But if it's not, you can do a symptom diary to help identify other causal foods. And then on your physical exam, you're going to be looking for other atopic disorders. As far as making the diagnosis, so the clinical history is very important, as we've talked about, but then you can do other things to help confirm the diagnosis. So we do have both skin and laboratory testing. The skin testing is what I'm going to be doing in the office usually, and laboratory testing are going to be like immunocap testing. Both of these tools are looking for the presence of a specific IgE antibody to a protein in the food. They do have some benefits, and so they do have a good negative predictive value, especially if you don't have a good history and you have a negative test. It tells a lot about that not being likely to be an IgE-mediated food allergy reaction to that food. But the downside is they do have a very high false positive rate, so almost the flip of a coin. And so you have to be very careful and be, you don't want to send testing on lots of different foods. You want to be very specific in the food testing that you order. When after history and doing whatever testing might be indicated, you're still not clear on the diagnosis, really the gold standard is doing an oral food challenge. And I do these all the time in my clinic in induction into food trials, food allergy studies. Usually the challenge is a double-blind placebo-controlled study, but in our clinical setting, we're usually just doing an open challenge, a graded dose challenge, exposing the child to increasing amounts of that food, and then looking for a potential reaction that could indicate a food allergy. So I mentioned, I kind of gave a bad rap to IgE-mediated testing. So, but I think there is some benefit to knowing what it tells you. And so what does IgE-mediated testing tell you about a food? So what it does tell you is the likelihood of a true IgE-mediated reaction to that food. So as the number in the blood goes up, or as the size of the skin prick test increases, that child is more likely to have an IgE-mediated reaction to that food. Now, again, it's not 100%, but the higher it gets, the more likely it is. What it doesn't tell you is the severity of that reaction. So I've had parents come in and say, oh, my child has a very severe peanut allergy. And I'll say, how do you know? And they'll say, well, their peanut specific IgE is greater than 100. Is that child likely to have a reaction to peanut? Yes. But does it tell us anything about the severity of the reaction to peanut? No, it could be a single hive or two, or it could be full-blown anaphylaxis. And then, you know, there is each value for each different kind of food has a different meaning. It's all based on previous studies looking at what the value was, what the test was, and then the outcome of an oral food challenge to help determine the likelihood of that child passing or truly being allergic to that food. So really that's more for an allergist to know and help them try to understand and decide, you know, how likely they are to pass or fail. And then if they're still unclear, going forward with a food challenge. And then one last point, you know, is because of a lot of these reasons, panels or broad screening testing really shouldn't be done. And really a quick note on this is, you know, you might, you know, see a patient where there's a very unclear history. You don't really, you know, there's some concern about a food allergy. You know, it doesn't meet really the standard kind of criteria for what you would think about as a food allergy. So, you know, but the parents are concerned. So you send a food allergy panel conveniently, you know, in the blood, and then this is what you get back. And so you can see that on here, not only did you get foods that probably the child wasn't even eating at the time of the reaction, but then several of them are flagged. The question is, what does that mean? I don't know what some of these mean, honestly. And if the child is eating the food before and not having a reaction, I'll tell you it clinically means very little. But it can lead to the overdiagnosis of food allergy and actually be associated with decreased quality of life in those patients. So, and another kind of point on why this is really important is that there is some good evidence that food elimination and strict avoidance of a previously tolerated food can actually induce a food allergy. So you don't want to do that. So in one study, this retrospective study, looking at around 300 patients that had atopic dermatitis, where a food was eliminated and strictly avoided from the patient's diet because of concerns that it was maybe worsening their eczema. And then upon follow-up about a year and a half or so later, it was found that 19% of these children that were strictly avoiding food went on to actually develop an immediate reaction to the food. And so, you know, you might be thinking, well, it's probably, maybe it was mild. Actually, in those 19% of kids that had immediate reaction, 30% of them who were tolerating the food before ended up having reactions that actually met criteria for anaphylaxis. So the first job that we have is to do no harm. And if really, if there's no clinical clear signs of an adverse reaction, I would tell you have a very high threshold of removing that food. And even if there is evidence of sensitization, if that child is tolerating that food and there's no clear immediate IgE-mediated reaction going on, I would petition you to not remove that food from the child's diet. All right, so what about natural history of food allergy? Well, it is actually variable depending on what food is implicated in the IgE-mediated allergy. So some foods like egg and milk and soy and wheat tend to resolve with age. Other foods like peanut, tree nuts, fish, and shellfish tend to be more lifelong. In those foods that are associated with children outgrowing their allergy, a declining specific IgE antibody to that food is oftentimes associated with them outgrowing the food. And so that's something that as I'm following these children in my office, that I'm looking for and will follow over time. And when they get to the point where I think that there's you know, a 50-50 shot that they might have outgrown the allergy, we proceed with a food challenge. There are some factors that have been shown to be associated with more persistent disease, including more severe reactions, lower threshold to cause or elicit reactions, earlier diagnosis, and other comorbidity, specifically in atopic diseases. But truthfully, you're going to put more on, you know, sort of the history, when the last reaction was, and then kind of how the testing is changing with time. As far as management goes of IgE-mediated food allergies, so if you are concerned that this is going on in your patient, you're going to recommend avoidance of that food allergy, and you would generally recommend strict avoidance. You're going to provide them with an emergency action plan, so that kind of goes over what to do should they have an accidental exposure at home, how to recognize and how to treat an allergic reaction should one occur. And then you're going to provide them with a prescription for an epinephrine auto-injector. And more importantly, you're going to teach them how to use it. And any person that's going to be taking care of that patient, a babysitter, a daycare, should also be well versed and understand how to use an epinephrine auto-injector. So I always have the parents that, make sure that they use the trainer that comes with the prescription to show anybody that's taking care of their child how to use it should they need to. As far as a couple quick things on dietary elimination. So you're going to have to, the patients now, they weren't avoiding a food. Now they're going to have to start strictly looking at ingredient lists, and they're going to be throwing a lot of different things. If you haven't looked closely, start looking at ingredients on foods. There's a lot of different labeling that you can see. And so really quickly, there is something called the Food Allergy Labeling and Consumer Protection Act, which basically says at this point in time that it is a law if a company, if one of the top 8 highly allergenic foods that we talked about is an ingredient in that food, they have to say in bold lettering at the bottom of the ingredient list, this food contains X, whatever food that is. And I will say sesame is currently undergoing some legislation to become the 9th food on that list. But what you'll also see are these advisory warning labels. They can say things like, this food may contain, this food was processed in the facility as, etc. There's lots of different advisory warning labels. And the truth of the matter is, this is not a law. This is completely the choice of the company to either put on this label or not put on this label. They don't necessarily always mean anything. And so, the main one you want to avoid is if there actually is an ingredient. As far as the advisory warning labels, I usually have a conversation with my patients and we talk about what they mean. And I usually emphasize it's probably more important to, be able to recognize an allergic reaction and be prepared to treat one should one occur. There are certain issues when cross-contamination is a more likely problem, such as in situations where there might be shared equipment, so in restaurants, ice cream parlors, bakeries, for example. And there's certain times, so for example, with tree nut allergy, you might be a little bit more careful, or peanut allergy, you might be a little more careful going to a bakery or to an ice cream parlor, as well as certain Asian cuisines that tend to use more of those nuts in their cooking. All right, so that's IgE-mediated food allergy. Our next case is here. And so now you're seeing a 6-month-old healthy male without a history of food allergy or eczema who presents with a well child visit. His mother has introduced a few single-stage fruits and vegetables without a problem, but she has not yet introduced peanut because his father has a nut allergy. Which of the following is the best recommendation for this patient? So would you want to A, introduce peanut at home in an age-appropriate fashion, B, obtain a serum-specific IgE, C, obtain a serum-specific and egg-specific IgE, or D, refer to allergy immunology for further evaluation? So go ahead and put your polls in if you'd like. We'll give you about 5 to 10 seconds to do so. All right. Let's see what we got. All right, perfect. I love it. 96% of you guys got this question right. I love it. And so this really kind of hits on the current recommendations for the introduction of peanuts. And so just a quick historical summary of where we've come from and where we are now. So back in the early 2000s, we used to say, some of these highly allergenic foods, maybe it's a better idea to withhold them, introduce them at a later age, maybe around 4 or so, because we want the immune system to sort of mature before doing so. We want the child to be able to vocalize if they're having a reaction. But really, these recommendations were made without really any evidence of the matter. And what ended up happening is the incidence of food allergy, particularly some specific foods like peanut allergy in particular, continued to be on the rise and continued to increase. And so in 2008, we came out with a statement that said, you know, we're not really sure. Maybe there is some benefit of introducing early, but we don't know that actually withholding and waiting to introduce is really the right way to go. And then really the groundbreaking study occurred in 2015, which was the LEAP study, or Learning Early About Peanut Allergy. This was the first really major evidence for the benefits of early introduction. And in this study, it was really with peanut. So I'm sure a lot of you have heard about the LEAP study. I'm not going to go into a ton of depth about the study, but I want you to understand what they did. So they took 640 infants who were at high risk for having a peanut allergy, which they defined by having moderate to severe eczema and or an egg allergy. And they skin tested these patients. So they either had a skin test that was negative to peanut, or they had a skin test that was low positive. So in our practice, by definition, a positive skin test is one that is 3 millimeters in average wheal size or greater. And they took patients that were that had skin tests positive from 1 millimeter wheal all the way to 4 millimeters. So even kids that technically had a positive skin test, and they included them in the study. Kids that had a 5 millimeter wheal size and greater were excluded. And what they did was then they randomized and either had half of each cohort introduce peanut early and the other half strictly avoid peanut. And then they looked again at 5 years of age to see what the incidence of peanut allergy was within the two groups with a double-blinded placebo-controlled food challenge. And here were their results. So pretty striking. In the skin test negative cohort, so these were the kids that on the induction into the study had negative skin testing, there was an 86% relative reduction in the prevalence of peanut allergy. Pretty striking evidence for primary prevention, right? Well, what's even really cool, even cooler, I would say, is that in the skin test positive cohort, these are kids that are already starting to go down that pathway, that are already starting to show sensitization. They also had about a 70% relative reduction in the prevalence of peanut allergy. So really, really striking evidence that at least for early introduction of peanut had some significant benefits. And why this is important for peanut is because, as I mentioned earlier, if you have or become allergic to peanut, you only have about a 20 to 25% chance of outgrowing that allergy with time. So it tends to be more lifelong. That study led to the change in the peanut introduction guidelines, which really recommended, sort of early introduction for all children, but those children that had increased risk factors, which they really took from the LEAP study of being severe eczema or egg allergy or both, doing some screening ahead of time. So you can either grab a peanut-specific IgE, and if it's less than 0.35, you can just go ahead and recommend, either introduction at home. If the family's nervous, you can have them feed in the office. If it's greater than that, there's recommendation for referral to allergy immunology to do further evaluation. And then we're oftentimes doing peanut skin prick testing. And then it's really helping us triage how we introduce that peanut. So if it's lower, we'll do a graded dose food challenge. If it's greater than an 8 millimeter wheal on that skin test, that's really associated with a 95% positive predictive value of that child having peanut allergy. So we have some, shared decision-making as far as what to do in that case, but a lot of those kids we end up avoiding and then reevaluating in a year. All right, so that's peanut. What about other highly allergenic foods? Well, the same group actually, which was again in Europe, in the UK, did another study that was cleverly called EAT, or Inquiring About Tolerance. And in this study, they prospectively evaluated the early introduction of the following highly allergenic foods, starting at either 3 months of age, and they compared it to a group that just had standard introduction, which was based on the parental preference at around 6 months of age. And the foods that they looked at were early introduction of cow milk, peanut, egg, sesame, fish, and wheat. And so what they did was then they came back, and at 1 year of age, they went to look and see who, they did food challenges to see what the outcome was, comparing the placebo group of standard introduction versus early introduction. And what they found was there was actually, while there was a lower prevalence of any food allergy in the early introduction group, it wasn't statistically significant. Kind of a bummer, right? Well, there is a little bit more to the story. And so as it turns out, while the ability to follow the protocol in the LEAP study was very high, the availability of these parents to be able to feed some of these foods to 3-month-olds was very difficult. if you can imagine trying to feed, egg and fish to a 3 or 4 month old, it can be very challenging. And so the ability to follow the early introduction protocol was quite poor. But so what they did was they took and they did a per protocol. So those that actually could do what the goal of the study was, there did seem to be a statistically significant advantage to early introduction. And then they did this adjusted per protocol, which is all they did here was they took the patients in the early introduction group that were already allergic when they first started to react, and they removed them from both groups. So they removed that number of patients, and there still seemed to be a significant benefit for early introduction. And the driving factors, well, that's any kind of food allergy. The driving factors were really found to be for peanut, for one, and you can see here that, again, in the intention to treat group, so this is everybody, there was a trend to be significant. And then as you look at the per protocol and the adjusted per protocol, there were really no peanut allergies in that early introduction group. The other food that showed some evidence was egg. And again, in that in that intention to treat group, there was a trend for significance to some extent, but in the per protocol and the adjusted per protocol groups, when you looked and analyzed it that way, there was a significant benefit for the early introduction of egg. So I think that there's some important points to point out here of why the differences there, even though there still seems to be a benefit of early introduction in EAT, why was it so striking in LEAP versus EAT? So, the first thing to keep in mind is that the population was very, very different. In LEAP, it was a high-risk population where they had eczema, they had another food allergy potentially. In EAT, this was just a general population. While there were some people that had eczema, there were a lot of individuals that didn't have eczema and didn't have other risk factors for developing a peanut allergy or any allergy. The other thing that was different is the time between the control and early introduction group. So in LEAP, there was over 4 years difference between the control group of introduction and the early introduction group, because I told you, as I mentioned, they reevaluated kids at 5 years of age after introducing in the early introduction group between 4 and 11 months. In EAT, there was only a few months different because a lot of those families in the standard introduction group started to get these foods in starting at around 6 months of age. And then, as I mentioned already, the percentage of patients that were able to meet the protocol was significantly different in LEAP versus EAT, with less than half being able to follow the protocol in EAT. So quite different between both studies. All right, so speaking of egg introduction and benefits of early introduction for egg, there have been 6 randomized controlled trials looking at the early introduction of egg, and that includes the EAT study that we talked about already. I'm not going to go through these here in detail. I threw them on here in case you wanted to review at a later date, but just in summary, a lot of these are smaller studies. A lot of them looked at like sort of other markers for developing food allergy. So for example, differences between sensitization and not true food allergy, which we've talked about, is a big difference. And then in one study here, they actually had to stop the study short because a lot of patients, at the time that they were introducing already in a high-risk population that had eczema, they were already having pretty striking reactions to egg at that point in time. So a more recent study that was done pretty well was called the PEDIT trial. And what they did here was they did a 2-step introduction of egg. So they took 147 high-risk infants. They started with a really small amount, 50 milligrams of this heated egg powder, which is about 25 milligrams of egg protein. Just to keep in mind, a whole egg is about 50 grams. So this is a very small amount, and they equate it to kind of like what you would be doing starting off with an oral immunotherapy process, for example. So they started this amount at 4 to 6 months of age and continued it for 3 months. And then after 3 months, at around 9 months of age, they increased that amount to 250 milligrams, still a very small amount. And then at 1 year of age, they challenged these infants to an oral open food challenge to 7 grams of this, again, heated egg protein, which was about 32 grams of a boiled egg. So just to give you keep in mind, that's over half of a boiled egg. That's a lot. That would be enough that I would, what I would do a food challenge with in my office. And so they actually ended the study early after an interim analysis of only 100 patients. And the reason was it worked. It really, really worked. So this looks very similar to what we saw in LEAP. In the intention to treat group, there was a 79% relative reduction in egg allergy prevalence between the two groups. And again, in the per protocol analysis, so those that were able to follow the protocol, almost a 90% relative reduction of egg allergy prevalence. So, and then all of these studies that I quickly mentioned were kind of looked at and studied in a recent meta-analysis, and their findings kind of go along with what I just told you. So there does seem to be a low to moderate level amount of evidence for the early introduction of egg, with an absolute risk reduction of about 37 fewer cases of egg allergy per 1,000 people that you would do this in a population with an egg allergy preference or incidence of around 9%. So that's a little higher than our prevalence here, closer to what the prevalence is in like somewhere like Australia. All right, so moving on to case 3, hopefully you're still there. We'll kind of change gears a little bit. So in case 3, you're seeing a 3-month-old healthy male who presents to your office with blood-streaked and mucousy stools that started over the past week. He is breastfed and has gotten good weight gain. His mother reports that he has otherwise been well. What is the next best step in your management? So do you want to A, start an amino acid-based formula? B, do you want to start an extensively hydrolyzed formula? C, do you want to start a soy formula and send cow milk serum-specific IgE testing? Or D, do you want to continue breastfeeding and remove dairy from the mom's diet? So let's go ahead and have you weigh in, see what you guys think.
And Dr. Prince, we do have just a few more minutes left.
Oh, okay. All right, well, why don't we go ahead and see what we have. Perfect, 97% got it correct. All right, so you're gonna continue breastfeeding. And so what I was kind of pointing out here was food protein-induced allergic proctocolitis, which really is a clinical diagnosis of painless gross blood in the stool during the first 6 months of age. What's really important in this case that I pointed out was that there's no history of failure to thrive. Most commonly occurs in breastfed infants. Most common trigger foods include cow milk, eggs, and soy. You can try a soy formula. You can try an extensively hydrolyzed formula, but I was trying to point out this was a breastfeeding infant who's 3 months of age that would benefit from continuing to breastfeed if mom is interested in removing dairy from their diet. Management, so the symptoms are going to resolve after about 72 hours of food removal. There's no role for IgE testing because this is not an IgE-mediated disease. And then it typically resolves by a year of age. And you can just have the family reintroduce at home. And if symptoms resolve, they've outgrown it. All right, we've got 2 more cases. So we're almost there. Case 4, and these should be pretty quick. You have a 15-month-old male with eczema who's presenting with a history of failure to thrive and non-specific vomiting. Caloric intake is sufficient, and the patient is currently tolerating cow milk, eggs, and peanut without any immediate adverse reaction. What is the next best step in the management? Do you want to send an IgE-mediated food allergy panel? Hopefully that's not picked in this case based on what I've told you. Recommend strict peanut avoidance, refer to GI for upper endoscopy, recommend starting an increased caloric supplemental formula. And we'll just give you guys a few seconds to sort of weigh in. All right, let's go ahead and see kind of what people thought. Perfect, so 73% of people got this correct. That is the answer. The one thing on your differential that you might be thinking is eosinophilic esophagitis, and definitely not diagnosed based on that clinical history, but just that history in general makes you think about it. So it's a type of eosinophilic gastrointestinal disease. There is a variable presentation based on age. So infants and young children present similarly to how I described here: progressive emesis, abdominal pain, and failure to thrive. Again, this is very different than that milk protein proctocolitis. Older children will present more with dysphagia, reflux-like symptoms, or even food impactions. They'll get food stuck and have to take smaller bites because of that. And then, the etiology and pathogens is not completely clear. It's a newer sort of disease entity, but I will tell you the most common food that's implicated in this is milk, followed by wheat, egg, and soy. And there are some other food triggers in there as well. And then you make the diagnosis based on endoscopy. So you're going to see greater or equal to 15 eosinophils per high power field on biopsy. Eosinophils really shouldn't be in your esophagus. That sort of 15 is what has been just sort of established as diagnostic criteria, but you can also see gross appearances of other abnormalities. You can see linear furrows, you can see cobblestoning, you can see these white plaques, which are actually clumps of eosinophils. And then what you can kind of try to do is a food trigger can maybe be established by a stepwise removal and then repeat endoscopy. there's really little benefit for skin prick testing, specific IG testing, and patch testing, although we sometimes do it. And then as far as management of this disease entity, so PPI therapy can be helpful. We used to think of that as a separate disease, but now it's sort of all thought to be eosinophilic esophagitis. Some will respond with PPI therapy. The other two mainstays of therapy are going to be either specific dietary elimination or swallowed topical steroids. The thought is that this is more of a chronic disease, but again, it's more of a recently sort of discovered disease in the sense that we're just still learning more about it. All right, moving on to our final case. So you have a 7-month-old female who's presenting to your office after having 2 episodes of severe vomiting and lethargy. Mom reports that symptoms occurred 2.5 hours after eating rice cereal mixed with cow milk formula. She is otherwise formula fed and has introduced a few single-stage fruits and veggies without problems. What is the next best step in management? So you can go ahead and put it up there. Yep. So do you want to start an amino acid-based formula and refer to GI for endoscopy? Do you want to start a soy formula and obtain serum-specific IG to cow milk? Do you want to recommend strict gluten avoidance and obtain tissue transglutaminase and endomysial antibodies? Or do you want to recommend strict avoidance of rice and oat and refer to allergy? So what do you guys think? All right, and I think we can go ahead and maybe even see. Perfect, so 63% of you guys got it correct. What I was looking for here was that this history is very much so concerning for what's called food protein-induced enterocolitis syndrome, which we conveniently call FPIES. So this actually tends to present in infancy. It has 2 different forms of presentation, an acute form or a chronic form. The chronic form is really more of a progressive emesis that again is associated with failure to thrive. You oftentimes will see that in a milk or soy formula fed infant, where the acute form presents similar to what I described here with vomiting that's delayed with diarrhea, lethargy, pallor, usually 1 to 3 hours after eating the food. The most common foods are going to be milk, soy, rice, and oat, but many foods can cause this. And so it's sometimes a little bit more difficult to make the diagnosis. The majority of children only have symptoms to 1 food, but oftentimes you'll find multiple foods causing this reaction. And then in the US, there does seem to be cross-reactivity between soy and cow milk, as well as between different grains. So the diagnosis is actually made by having that clinical history. And so there is a diagnostic criteria, which I'll show you here in the next slide, but there are no specific diagnostic tests. And so really it's what's missing that's important. So unlike IgE-mediated food allergy, which there are some similarities here, you will not see urticaria, angioedema. You generally don't see coughing or wheezing and things of that nature. It's really this really severe, profound vomiting, oftentimes hypotension and pallor, lethargy. And so this is from the International Consensus Guidelines, which you can see cited there. You guys can take a look at it later if you want, but the major criteria is that clinical history, followed by minor criteria of it happening reproducibly to that food or happening to a different food, having that lethargy, pallor, and other associated symptoms. And you really, they define a diagnosis as the major criteria with 3 minors. And then they define a little bit further what you would tend to see in chronic FPIES. Management, epinephrine antihistamines are not effective. Generally, we're going to offer supportive care with fluids and antiemetics. You're going to want them to avoid the causes of food, start to introduce some safer foods, which are thought to be like green, yellow vegetables and fruits, but there's kind of low evidence because, like I said, it can happen to many different foods. Oftentimes, I'll present the family with a letter that they can give to their ED doctor just to kind of describe what's going on in case they're not aware of it. And then natural history, it does seem to be one that people outgrow. Usually 50% will outgrow after about 2 years. So really that has to be confirmed with a food challenge, which we again do in our office. So that's some quick brief cases that I just wanted to kind of throw out there for you and help think about food allergy as it applies to the patients you're going to be seeing. Some final take-home points are that there are really many adverse reactions to foods, and that detailed clinical history is really vastly important as you're developing your differential diagnosis. Food-specific IG testing can be helpful, but mainly in IgE-mediated food allergy, it's important to know it has a high false positive rate and that you don't want to have children eliminate foods that they're previously tolerating because that can induce a food allergy. There does seem to be some good evidence of early introduction for peanut and egg and helping reduce the development of allergies to these foods. Non-IgE-mediated food allergy oftentimes presents with gastrointestinal symptoms in the absence of some of those other IgE-mediated symptoms and can often be associated as a cause for failure to thrive. really the gold standard for any food allergy is going to be that oral food challenge, and the natural history of food allergy is very variable depending on the food that's causing the reaction as well as the mechanism. So with that, I'd be happy to take any questions. I can stop sharing my screen.
Hey, thank you, Dr. Prince. So the one question that I saw in the chat box, if anyone else has any questions for Dr. Adams or Kara, Kristen, or Dr. Prince, please put those in the chat box now. If we don't get to all of them, I will make sure that we get the answers for you. But the one question that we have for you, Dr. Prince, is what are your thoughts on spoonful 1 for allergy avoidance?
That's a really good question. And so for spoonful 1, the problem with spoonful 1 is that it's not actually, there's not a significant amount of allergen for each food in each serving. And so, you know, when you talk about early introduction, we're talking about, for the most part, outside of that one egg study, you're actually just introducing the food. And there's really no reason not to just introduce the food, doing it in a stepwise manner. I've oftentimes seen patients that have, you'll get, like I mentioned, feeding small, teeny tiny amounts of peanut. And then when they actually start to actually feed a larger amount, have a clear clinical reaction. So there's really not a lot of good evidence that that amount of food protein that's in spoonful 1 is really significant to do anything as far as prevention of food allergy. But that's a great question.
Great, thank you. Are there any other questions now?
I see one here. So how to introduce egg and peanut in kids where parents are severely allergic and can't be exposed in the house. So really having the food that another food allergic patient, you know, say you have a sibling or a parent that's allergic to peanut, having peanut butter in the house really shouldn't pose a significant problem. Peanuts are not aerosolized, and so you can have an open jar of peanut butter in the house and it's not going to cause problems. I oftentimes equate this to parents by saying, do you keep chemicals in your house, cleaning products that if you ate them could cause problems? And the answer is yes, right? But we're just very careful about doing it. So if you do feed that food early, you want to make sure you minimize cross-contamination, wash any surface or utensil that you're utilizing to prepare a food that has that allergen on it with warm soapy water. And then studies as far as like that patient then not having leftover or residual protein on or in their mouth, one of the best things you can do is have them eat something else. And it's one of the best, most effective measures to help clear and cleanse that protein. It actually works better than brushing your teeth.
And I think there's one more in there too for you, Dr.
I have a 4-month-old with Down syndrome who is nursing, and mom seems to have enough milk, but is failure to thrive without another GI symptom. So celiac disease would probably be, less likely in this case. You could have mom, so as we talked about, so if you're wondering about failure to thrive, you're thinking about, probably either eosinophilic gastrointestinal disease or potentially like a food protein induced enterocolitis syndrome. Both of those are less common to happen with breast milk. And so I would, number one, make sure that you have good evidence that they're actually getting enough caloric intake. That can be really important. You could trial avoidance of like dairy, for example, from mom's diet. But if things don't get better after a few weeks and you don't see any difference in that sort of weight trajectory, then I think it's less likely to be that. If you confirm that they're getting enough caloric intake, then really, and they're still failing to thrive, then ruling out other chronic diseases would be important, such as, immune deficiency, things of that nature, metabolic diseases, and then maybe referring to GI just to make sure that they actually are not having, that they're able to absorb appropriate nutrients as well. But that's another very good question.
Great, thank you. And I think there was a few questions for Kara and Kristen in the chat box too. And I believe that they answered all of those. If there's any follow-up or anything like that, please let me know and I'll make sure that they get your questions and they're able to answer those. So that is it for the training today. And this is the last session for annual meeting this year. So we're so thankful that you all were able to join us yesterday and today. As a few reminders, the Parenting at Mealtime and Playtime program with Ohio AAP has some exciting changes. some new trainings coming up, a toolkit and a journal club. Our next training will be on December 10th, Wellness During a Pandemic, Rising Importance and Unique Opportunities. Dr. Christopher Bowling will be presenting during this training. The link to register is on this flyer, and the link for the toolkit and the journal club are also here on this slide. Please feel free to email me with any questions that you have at amiller@ohioaap.org. Again, please send any additional questions that you have about this training, and I'll make sure that the speakers get it. Thank you again to Dr. Adams, Kara, and Kristen, and Dr. Prince for being panelists during this session. We are so thankful for the information that you were able to share, and I hope everyone has a great rest of your weekend.
See you
Thank
guys.
you all.